All right, if you've got exams coming up, you know typhoid fever is a big one. So in this explainer, we're gonna cut right to the chase. No fluff. We're breaking down the pathology, diagnosis, and management into just the key points you'll actually see on your test. Let's dive in.
You know, the best way to really get a handle on typhoid is to think of it less like a random infection and more like a planned invasion. So the question we're going to tackle is this: how does one tiny bacterium manage to lay siege to the entire human body for 3 whole weeks? It's a fascinating story.
So here's our game plan. First, we'll meet the villain of the story. Then we'll track its invasion, focusing on a key location called the Peyer's patches. We'll map out that classic 3-week clinical timeline, then cover diagnosis and treatment. And we'll wrap it all up with a rapid-fire summary of the absolute must-know facts.
Okay, Section 1. Let's meet the culprit. Before we can talk about the disease, we've got to understand the organism at the heart of it all, Salmonella Typhi.
So what is this thing? Well, it's a gram-negative bacterium. It spreads through the fecal-oral route. Think contaminated food or water. But here is an absolutely critical exam fact. Humans are its only reservoir. It's a human-to-human disease, which has huge implications for public health.
So how is this tiny organism so good at what it does? It comes prepared with a whole arsenal. It has these type 4 pili, which are like little grappling hooks to latch onto your cells. It's got a viral antigen capsule, which is basically a stealth cloak that helps it hide from your immune system's first responders. And then it has pathogenicity islands. Think of these as the blueprints for its weapon system, allowing it to inject proteins directly into your cells to cause damage.
And get this number in your head, 6 to 30 days. That's the incubation period. It can be almost a month from when someone is exposed to when they actually feel sick. And that's a huge deal, right? Because it means a person can be walking around spreading the bacteria long before they even have a clue they're infected.
So we've met the invader. Now, for Section 2, the invasion itself. And the story of this invasion begins at a very specific place, the Peyer's patches.
Let's trace the path. After someone ingests contaminated food or water, the bacteria make a beeline for the Peyer's patches in the small intestine. Think of these as the weak points in the castle wall. They invade these patches, get scooped up by immune cells called macrophages, and then they basically hijack them for a ride into the bloodstream. That's wave number 1, the primary bacteremia. From there, they set up shop in organs like the liver, spleen, and gallbladder to multiply. Then they launch a second, much bigger wave back into the blood, and it's this secondary bacteremia that really kicks off the classic symptoms of typhoid.
And once that second wave hits, the clinical battle truly begins. This brings us to the 3-week siege. For your exam, you have to know this timeline, because the symptoms change pretty dramatically from one week to the next.
Let's break it down. Week 1 is kind of vague. You've got a headache, some GI issues, and this slowly rising stepladder fever. But there's a huge clue here we'll talk about in a second. Then in week 2, the fever is high and persistent, and this is when the classic signs pop up: rose spots on the abdomen and a coated typhoid tongue. By week 3, things can get really serious. This is when the risk for major complications, like the Peyer's patches actually perforating, is at its highest.
Okay, I really need you to lock this in because it's a favorite exam question. Normally, when you get a fever, your heart rate goes up, right? For every degree Celsius your temperature rises, your pulse should jump by about 10 beats per minute. That's tachycardia. But with typhoid, something strange happens. The fever spikes, but the pulse just doesn't keep up. This disconnect is called relative bradycardia, or FMGE sign, and it's a massive clinical clue that should make you think typhoid.
And here's a closer look at those other classic signs from week 2. You've got the rose spots, these faint salmon-colored little dots, usually on the abdomen and chest. And then you have the typhoid tongue, this really thick white coating right down the middle. Now these are classic, but just remember, you won't see them in every single patient.
So we see the clinical signs. We suspect typhoid, but how do we prove it? This brings us to Section 4, the investigation.
For diagnosis, timing is absolutely key. In that first week of symptoms, the gold standard is a blood culture. That's your best bet. Later on, as the bacteria colonize the gut, a stool culture might turn positive. But if you're asked for the single most sensitive test, that's a bone marrow culture. It's invasive, sure, but its big advantage is that it can find the bacteria even after someone's already started taking antibiotics. Now, you're definitely going to read about something called the Widal test. This test looks for antibodies against the bacteria. And here's what you need to know for your exam. It is no longer recommended.
Why? Well, it's just not very reliable. It has low sensitivity and specificity, and it can be positive if you've had a past infection or even certain other illnesses. So you need to know what it is, but more importantly, know that we don't use it for diagnosis anymore.
So, the diagnosis is confirmed. It's time to launch the counterattack. Let's talk about treatment.
For straightforward cases where the bacteria isn't resistant, the go-to drugs have been fluoroquinolones, like Cipro. But, and this is a big but, drug resistance is a huge and growing problem. So for those resistant strains, we turn to third-generation cephalosporins. And for the really tough, multi-drug resistant cases, azithromycin is a key player.
And what about really severe cases? Well, the care definitely escalates. We're talking intravenous antibiotics, like ceftriaxone. If the brain is involved, if there's delirium or meningitis, we add IV steroids to reduce inflammation and improve outcomes. For the extensively drug-resistant or XDR strains, we have to bring out the big guns, like meropenem. And of course, if that dreaded complication of ilioperforation happens, it becomes a surgical emergency, stat.
Now, here's a really important long-term issue, the chronic carrier state. This happens when someone recovers from the illness, but the bacteria essentially set up a permanent hiding spot in their gallbladder. The person feels totally fine, but they continue to shed bacteria in their stool for over a year, sometimes for life, unknowingly posing a huge risk to everyone around them.
All right, we've gone through the whole story. Now let's lock in everything you need for your exam with a super fast, rapid-fire review. Ready?
Here we go. Organism, Salmonella Typhi, gram-negative. Reservoir, humans only. Key invasion site, Peyer's patches. Hallmark sign, relative bradycardia. Classic finding, rose spots. Gold standard for diagnosis, blood culture. The outdated test you need to know about, the Widal test. Treatment for severe cases, IV ceftriaxone. And for XDR, meropenem. And finally, where does it hide in a chronic carrier? The gallbladder. You got this.
So, I'll leave you with a final thought to chew on. Knowing that this bacterium can hide out for years inside a perfectly healthy-looking person, what does that tell us about the massive difference between just treating one sick patient and the much, much bigger challenge of actually curing an entire population? That's it for this one. Good luck with your studies.